හරි. මම මේ කලින් අවුරුද්දට ප්‍රශ්න ටිකක් දාලා මේක හැදුවේ. මේකේ උත්තර තියෙන වෙනම ඩොකියුමන්ට් එකක් තියෙනවා. මම මේක කරගෙන යන ගමන් ඒක පෙන්නන්නම්. දැන් පටන් ගන්නම් එහෙනම්. ඉංග්‍රීසි සිංහල දෙකෙන්ම මික්ස් එකෙන් කියන්නම්. ජරණත් ඉන්න හින්දා. So first one is regarding left ventricular dysfunction. Valvular dysfunction is a known etiology. True. And fatigue is a recognized feature. That is also true. In Kumar Clark, it is also mentioned fatigue as a prominent symptom. Other symptoms are extrational dyspnea, orthopnea, and PND. And fatigue is also a symptom. And beta blockers are best avoided if systolic dysfunction is less than 40%. That means ejection fraction is less than 40. Beta blockers are indicated. The evidence regarding beta blockers is only for the ejection fraction below 40%. That is reduced ejection fraction. So that is false. Beta blockers are indicated. ACE inhibitors have no prognostic benefit. That is also false. ACE inhibitors have prognostic benefit. There are mainly 7 medications that have prognostic benefits in heart failure. Those are listed here. They are beta blockers, ACE inhibitors, so ARB, ARNI, and mineralocorticoid receptor antagonists, spironolactone, and SGLT2 inhibitors, and the combination of hydralazine and ISDN. So those are the only drugs with a survival benefit in heart failure. You should know this. They frequently ask these medications. And CRT is a treatment option. CRT means cardiac resynchronization therapy. That is a treatment option in advanced heart failure. Also, ICD is also another treatment option. ICD means implantable cardiac defibrillator. Let's move on to the second question. Increased sympathetic output to the heart results in reduced stroke volume. That is false. This is the formula of the cardiac output. Cardiac output equals stroke volume into heart rate. Sympathetic input increases heart rate as well as the stroke volume. It increases preload, afterload, and contractility. So both stroke volume and heart rate is increased with sympathetic output. Stroke volume depends on these factors. So reduced stroke volume is false. It is actually increased. And increased cardiac output true. Decreased coronary perfusion is true. Coronary perfusion usually happens during diastole in the cardiac cycle. So with increased heart rate, the time in diastole is reduced. That is because of that, coronary perfusion is reduced with increased sympathetic output, and oxygen demand is increased with sympathetic output, and ejection fraction is actually increased with sympathetic output. Next section, 68. This is a SPR. 68-year-old man transferred with anterior STEMI, and he has clammy and sweaty with rapid deterioration. So he's unstable, and cardiac monitoring shows broad complex tachycardia. So this is a ventricular tachycardia, and the patient is unstable. Femoral pulse impalpable, blood pressure low. So what is the next step of management? So in any arrhythmia, if the patient is unstable, usually we do DC cardioversion. So in this case, with VT, this is VT with pulse, VT without pulse. So, however, this is not cardiac arrest because the patient is, if it has, for it to be a cardiac arrest, the patient has to be unresponsive. Here it does not say that patient is unresponsive. However, he is hemodynamically unstable. Therefore, if we take in this side, VT with pulse, the patient is unstable. We have to give synchronized DC cardioversion. However, if the patient is stable, then we can go with IV amiodarone or DC cardioversion. So what you have to remember is for VT, if the patient is unstable, DC cardioversion. If the patient is stable, we will go with IV amiodarone. Next one is also an SPR. 60-year-old male with heart failure, hypertension, and dyslipidemia. Presents with worsening exceptional dyspnea for 2 months. Tachycardic, irregular pulse, BP is normal. So already on ACE inhibitor, beta blocker, and thiazide, ejection fraction 35. So this patient has heart failure as well as he has atrial fibrillation. And they ask which drug provides survival benefit. Digoxin provides rate control in atrial fibrillation. However, it does not have any survival benefit. Ivermectin also, although it is used in heart failure, it does not have any survival benefit. Spironolactone has survival benefit in heart failure. Calcium channel blockers and GTN also does not have any survival benefit in heart failure. Therefore, the only remaining answer is spironolactone. This question is also based on the same principles as this one. So you have to remember these heart failure medications with survival benefit. Question 5. 45-year-old man with long-standing hypertension, BP very high, with despite good adherence, and ambulatory blood pressure measurement confirms uncontrolled hypertension, no secondary cause. Currently on amlodipine, calcium channel blocker, losartan, ARB, and hydrochlorothiazide. So the patient is on 3 antihypertensives, including a thiazide. What is the next step of management? This is resistant hypertension. What is meant by resistant hypertension is blood pressure that remains above goal despite use of 3 antihypertensives, with one being a diuretic. One has to be a diuretic with optimal doses. Now these are optimal, although we don't have to remember any doses. They have given some doses here, so we don't have to know them, so we can consider them as optimal doses. So in this context, the next option is adding spironolactone. For resistant hypertension, spironolactone is the drug of choice. Next question, 35 year. If you have any questions, you can ask. Next question. A 35-year-old previous well woman with worsening breathlessness for 1 week. Initial mild fever, malaise, weakness, arthralgia, and myalgia. This seems like a viral infection. Now, orthopnea and PND. Examination reveals dyspnea, elevated JVP, bilateral ankle edema, case crepitations, gallop rhythm, and mild systolic murmur. So this is heart failure with features of viral infection. And full blood count, lymphocytes are elevated, ESR is high, and ECG, there are T inversions as well as atrial fibrillation. Although, so in this type of a question, we don't have to know all the stuff to come to an answer. So we know this patient has heart failure and also features of a viral infection. So out of these answers, we can think of viral myocarditis here. In infective endocarditis, mainly a neutrophil leukocytosis will happen. And this is obviously not ischemic heart disease. And there is no evidence of saying the patient has cytotoxicosis or uremia. This is a previously well patient. And in myocarditis, diffuse T inversions occur as well as various arrhythmias can occur. So here atrial fibrillation has occurred. So we can, with these facts, we can come to an answer of viral myocarditis. So in up to now, we discussed the 2014 A-level paper, CVS MCQ. Next, we have 2015 A-level CVS MCQs regarding renin-angiotensin-aldosterone system. These type of questions come frequently in MCQs. This is a common topic. This has been asked multiple times. Renin secretion is induced by ANP. Because ANP is secreted when atria are stretched in during congestion, and ANP inhibit renin secretion. So this is false. Angiotensin II is produced in the liver. This is false because angiotensinogen is the one produced in liver, and it get converts to angiotensin 1 via renin in the kidney, and angiotensin converting enzyme in lungs convert into angiotensin 2. So angiotensin 2 is produced in the lungs. Angiotensin 2 stimulates ADH release from the hypothalamus. That is true. Although it is not given in this picture, it stimulates ADH secretion. Aldosterone acts on the distal convoluted tubules. That is true. Aldosterone has two places of action. One is the DCT and the other one is the collecting duct. Activation of the RAS is beneficial in chronic heart failure. That is false. It is not beneficial in heart failure. It actually worsens chronic heart failure. So question 8 regarding heart failure. This question also has been repeated multiple times with minor changes. Arrhythmia is a cause. That is true. So the main causes of heart failure are, the main one is ischemic heart disease. Then cardiomyopathy and hypertension comes. Then valvular heart diseases and arrhythmia also can be are causes of heart failure. Elevated BNP level helps in the diagnosis. That is true. BNP is secreted by ventricles when it is stretched. So BNP levels go up in heart failure. That is used to diagnose heart failure as well. NSAIDs worsen the condition. That is true. NSAID cause fluid retention in the kidneys, so it worsens heart failure. Furosemide improves survival. That is false. It does not have any evidence saying that it is improving survival. It improves, however, it improves symptoms. Question 9. A 53-year-old man presented with central chest pain. ECG showed ST elevations lead to 3 and AVF. So this is 2, 3 AVF means inferior STEMI. Regarding clinical scenario, troponin is required to make a diagnosis. That is false. In STEMI, STEMI is a ECG diagnosis. You don't need troponin to confirm the diagnosis. Sublingual GTN has a prognostic benefit. That is false. It only relieves pain, symptomatic benefit only. And thrombolytic therapy is superior to PCI. That is the other way around. PCI is superior to thrombolytic therapy. Caused by 100% occlusion, that is true. STEMI is caused by 100% occlusion, and STEMI less than 100% occlusion. Is due to eruption of an atherosclerotic plaque, that is true. Question 10. A 36-year-old woman who was in bereavement after losing her husband 2 weeks ago presented to the emergency department with central chest pain. Her troponin was elevated, ECG showed ST elevations in anterior leads, and echo revealed apical hypokinesia with EF 40%. Angiogram was normal. What is the most probable diagnosis? So here all the clinical features are suggestive of MI, and troponin was also elevated, and ECG is suggestive. Also, ECG is suggestive of MI. However, angiogram is normal. So this is a special condition called Takotsubo cardiomyopathy. Here what happens is when someone feels a lot of grief, then they can get a cardiomyopathy that mimics a STEMI. So that is what is called Takotsubo cardiomyopathy. But the difference between STEMI and this one is the coronary vessels are intact in Takotsubo cardiomyopathy. Recently, they have started asking about cardiomyopathies in MCQ. So, in the recent papers, one MCQ regarding cardiomyopathies is given usually. Question 11. A 79-year-old man with palpitations for 1 day, pulse irregular at 130, and BP normal, lungs clear, normal heart sound. So the patient is stable. Past history of hypertension and ischemic heart disease. ECG shows AF, chest X-ray normal. What is the next best drug to use? So this patient has atrial fibrillation, and the patient is stable. So if a patient has atrial fibrillation, first we have to see whether patient is stable or unstable. If the patient is unstable, then the only treatment is DC cardioversion. If the patient is stable, then we have to look into the risk of stroke. In atrial fibrillation, there's a risk of thrombus formation in the atria. So this risk is high if the onset of atrial fibrillation is more than 48 hours. And the risk is low if we can identify a clear onset less than 48 hours, or the patient has been on oral anticoagulants, that means warfarin or DOACs, for more than 3 weeks. So here it does not mention that the patient uh, has a clear onset less than 2 days, and the patient is not on any anticoagulants. So if the patient is low risk, then we can go for a cardioversion. Cardioversion, cardioversion means rhythm control that can be achieved by DC cardioversion or pharmacologically by IV amiodarone. If the patient is high risk of having a thrombus, then we have to go for rate control. For rate control, we can use the main drug is beta blockers. Then we can use non-dihydropyridine calcium channel blockers like verapamil and diltiazem or digoxin. So out of these answers, uh, amiodarone is mainly used for rhythm control. That means pharmacological cardioversion. However, it can be also used for rate control as well, but it is lower down in the line. Ivermectin is not relevant here. Digoxin can be used to do rate control. Diltiazem can be used to do rate control. Metoprolol also can be used. However, the first line drug is beta blockers. So here the answer is metoprolol. Atrial fibrillation also is a uh, area where they give they frequently question on. Next, we'll move on to 2016 A-level paper uh, regarding heart failure. They usually ask one question about heart failure in every paper. Atrial fibrillation is a cause, that is true. Arrhythmia is a cause. And edema is due to renin-RAS system, that is true. Edema is mainly due to two causes. One is the back pressure from the venous system, and the second one is activation of RAS system. Degree of BNP elevation correlates with severity, that is true. So we can quantify the severity of heart failure via the level of BNP. Preserved ejection fraction heart failure indicates diastolic failure. That is true. Heart failure is categorized into uh, three fractions based on the ejection fraction. Less than 40% heart failure with reduced ejection fraction. More than 50% heart failure with preserved ejection fraction. And between 40 to 49 heart failure with mildly reduced ejection fraction. So all the current drugs that have survival benefit are based are only for this heart failure with reduced ejection fraction. These drugs can be used for these two fractions as well, but they do not have any survival benefit in here. Survival benefit is only for this section. So back to the question, preserved ejection fraction heart failure indicates that diastolic failure. So in this section, the ejection fraction is more than 50. What happens here is the left ventricle becomes stiff. So the diastolic filling does not happen properly here. That is why it is called diastolic failure. And aldosterone antagonist has mortality benefit. That is true. Spironolactone has mortality benefit in heart failure. Question 13. Non-atherogenic causes for coronary syndrome. Cocaine use is true. Cocaine causes coronary vasoconstriction. Coronary emboli, that is true. Uh, And high density lipoprotein means HDL, that protects the heart from atherosclerotic coronary syndromes. So this is actually not relevant here. That is false. Coronary spasms, that is true. Coronary vasoconstriction. And stress cardiomyopathy, that is true. Stress cardiomyopathy means Takotsubo cardiomyopathy.
දෙමින්ද B එක චුට්ටක් ආයි කියපන්කෝ.
මොකද?
B එක coronary emboli කියන එක non atherogenic causes එකක්ද ඒක?
ඔව් එම්බොලයි කියන්නේ මේ කියන්නේ වෙන තැනකින් එන ඒවානේ.
right හරි. එලෙක්ට්‍රෝ.
Next question. Features of infective endocarditis. Clubbing is true. Microscopic hematuria is also true. What happens is renal infarctions can happen due to embolization, and also glomerulonephritis also can happen in infective endocarditis. That is why hematuria occurs in infective endocarditis. And lymphadenopathy is not common in infective endocarditis, so that is false. Pallor can occur in infective endocarditis due to various bleeding manifestations. And thrombocytosis, which means increased platelet, that is false. In fact, thrombocytopenia sometimes can happen. There are various manifestations of infective endocarditis, so they can ask about this in future questions as well. Embolic complications can affect any organ in the body. So in the spleen, it can cause splenic infarcts and splenomegaly. In the lungs, it can cause lung abscesses, and kidneys, renal infarcts, liver abscesses and infarcts, and splinter hemorrhages in the fingers, and skin, genital lesions and nostril nose, and eyes rot spots. In the heart, anything can happen. Heart failure, arrhythmias, myocardial abscesses, and even MI can also happen. Strokes also can happen during infective endocarditis due to embolization. Again, a question regarding RAS. Renin secretion induced by ANP false. This is basically the same question except for the last time. So the renin is induced by ANP false, angiotensin produced by liver false. Liver produces angiotensinogen. Angiotensin 2 stimulates ADH, that is true. Aldosterone acts on the PCT, that is false. It acts on the DCT and the collecting ducts. RAS is the most important mechanism in the development of edema and cirrhosis. That is true. That is in cirrhosis, out of the topic, in cirrhosis, ascites happens due to portal hypertension as well as low albumin and activation of the RAS system. However, RAS system is the most important mechanism. Next one, a 70-year-old male with sudden onset SOB, a non-hypertensive patient on losartan and HCT, BP very high, and bilateral crepitations present. What is the best drug to manage his high blood pressure? So BP 220 by 140 and bilateral crepitations. So this patient has a hypertensive emergency. There is heart failure due to pulmonary edema due to hypertension. So I took this chart from the Kumar and Clark. So in here, all the hypertensive emergencies have been listed out, and first line therapies for all the conditions have been listed. So IVGTN is used for management of hypertensive emergencies in acute coronary syndrome and acute pulmonary edema. For all the other hypertensive emergencies, that means hypertensive encephalopathy, aortic dissection, and preeclampsia, IV labetalol is used. So in ACS and pulmonary edema, which means basically heart failure, IVGTN is used because it has pulmonary venodilation properties. Question 17. A 27-year-old woman with low-grade fever, body aches and joint pains for 2 weeks. These are non-specific symptoms. Febrile pansystolic murmur at the apex, hemodynamically stable. Most appropriate next step. So with the pansystolic murmur, which we can think of a mitral regurgitation, and we can think that this is subacute infective endocarditis. So the most appropriate next step is first we have to do blood cultures. Then we have to initiate empirical antibiotics. And based depending on the blood cultures, we can later change the antibiotics. So the most appropriate next step is doing blood cultures. Echo, chest radiograph, and CRP levels can also be done to confirm the diagnosis. However, the most appropriate one is doing blood cultures. Next one is regarding an arrhythmia. 55-year-old patient present with giddiness and pulse is 150, irregular, and blood pressure is very low, 70 by 50. So the patient is unstable and with the irregular heart rate. So this is a patient with arrhythmia with hemodynamic instability. Immediate management is DCA cardioversion. This is a straightforward question. (2017) A-level MCQs. True or false clinical features regarding cardiac murmurs. Ejection systolic murmur at the left lateral sternal edge suggests AS. That is false. Left sternal edge, it is PS or flow murmur. Transsystolic murmur at the apex radiant to the axilla suggests MR. That is true. Opening snap mean MS murmur suggests calcified mitral valve. That is false. When the mitral valve is calcified, the opening snap disappears. So to have a opening snap, the valve has to be pliable. So it has to be not calcified. So that is false. Early diastolic murmur at the left sternal edge suggests AR. That is true. So the A, B, and D are easy stems in this question. And late systolic murmur at the apex suggests mitral valve prolapse. That is true. What is meant by mitral valve prolapse is the mitral valve cusps get weakened and During systole, they get bulged into the left atrium, and subsequently, it can progress into mitral regurgitation. When it progresses into mitral regurgitation, then what we hear is a late systolic murmur. In MR, usually we hear a pansystolic murmur. No? So in mitral valve prolapse, we hear a late systolic murmur. Here, the regurgitation only happens at the later part of the systole. So the next question. Causes for tissue edema in heart failure, congestive heart failure. So in 2017 also they have asked about heart failure question. Stress of afferent arteriole. That is true. Although in congestive heart failure, the cardiac output reduces and the renal perfusion decreases, due to venous congestion, the afferent arteriole is stretched out. Therefore, our system is activated via that. And excessive secretion of ANP, that is false. Although ANP is secreted in heart failure, ANP works to reduce the edema. It inhibits the RAS system. So that is false. Increased aldosterone production, that is true. Due to activation of RAS system, aldosterone is increased. Increased arteriolar hydrostatic pressure, that is true. Due to venous congestion, arterial hydrostatic pressure is increased. Therefore, fluid leaks into the interstitial compartment. So this is based on the Starling forces. Stimulation of ADH secretion, that is true. Angiotensin 2 stimulates ADH secretion from the hypothalamus. This was mentioned above. So the next question, it is a SBR. A 68-year-old male with intermittent palpitations, dizziness, and headache for 1 year. These are symptoms of some kind of an arrhythmia, and non-diabetes and hypertension. Blood pressure 120/90. Blood pressure is okay. ECG shows irregular rhythm with absent P waves. Absent P waves occur in atrial fibrillation. So irregular symptoms of arrhythmia, irregular rhythm, and absent P waves suggestive of this is atrial fibrillation. Suitable drugs for management. So in atrial fibrillation, this is a fairly old man, and onset of he has been having this atrial fibrillation for 1 year. So we cannot think of rhythm control here. We have to think of rate control. We can use this beta blocker or verapamil DSM for rate control. As well as we have to think of anticoagulation also. To decide on anticoagulation in atrial fibrillation, we use something called Chasles score. So atrial fibrillation is divided into mainly two arms. One is valvular AF, other one is non-valvular AF. Valvular AF means AF with mitral stenosis or prosthetic valve. So those are the only two conditions where AF is valvular AF, mitral stenosis and prosthetic valve. All the other conditions, even mitral regurgitation, is considered non-valvular AF. In valvular AF, warfarin has to be given. Chesvesco is not considered in valvular AF. It is considered only in non-valvular AF. Here it is not mentioned whether it is valvular or non-valvular, so we can take this as a non-valvular AF. So the components of Chesvesco are like this. So this patient has diabetes and hypertension. So diabetes carries 1 mark and hypertension carries 1 mark. So this patient's CHEST score is 2. If the patient has 2 points in CHEST score, oral anticoagulant has to be given. So warfarin or direct acting oral anticoagulant, that means rivaroxaban or adoxaban, those have to be given. Aspirin is not enough in this when CHEST score is 2 or more. So when considering answers, amiodarone plus warfarin. Amiodarone also can be used. This is also a fairly correct answer. Bisoprolol plus warfarin. Bisoprolol is the first line rate control drug, beta blocker. So this is the most suitable answer. Digoxin and warfarin, that is also a correct answer. Um, and the D and E aspirin is given, so those answers are false. So the most appropriate one is bisoprolol plus warfarin because it is a first line now. Uh, 22. 75-year-old male with acute onset tightening chest pain for 6 hours. Has mild renal impairment and hypertension. ECG shows left bundle branch block, which has also been there previously. Propy is elevated. Next best step of management. So this patient has ongoing chest pain for 6 hours. And his ECG does not show anything because this left bundle branch block has been there previously and propy is elevated. To answer this question, we have to know about the definition of a type 1 MI. So the definition is there has to be a rise or fall of propy values with at least one value above the 99th centile. So in this context, propy is elevated. And with at least one of the following: symptoms of acute myocardial ischemia, new ischemic ECG changes, development of EFs. Let's stop from there. And so this patient has elevated propy plus symptoms of acute myocardial ischemia. So we can consider this as a uh, myocardial infarction. By the way, type 1 MI is the atherosclerotic type. There are other types, type 2, 3, likewise. Type 1 is the atherosclerotic type. So here we can consider this as an MI. So for any MI, the best management is PCI. So therefore, the best management is prepare for percutaneous intervention. Last one, 65-year-old man with chronic heart failure attending routine clinic. Recurrent admissions for breathlessness in the past 6 months on enalapril, ACE inhibitor, furosemide, carvedilol, beta blocker, spironolactone, mineralocorticoid receptor antagonist, and atorvastatin. Most appropriate step to optimize his condition. So, although he is on 1, 2, 3, 4 drugs for heart failure, he still has recurrent symptoms. So, what is the most appropriate management? So, at digoxin, it can be done. It is heart failure medication. Empagliflozin is also heart failure medication. And ivermectin, metolazone, these everything are all of these are heart failure medications. However, metolazone is a loop diuretic. They have given one loop diuretic, furosemide, so we can cut that out. And digoxin, empagliflozin, and ivermectin, all three are heart failure medications. However, here the only one with mortality benefit is empagliflozin. So recently they have been questioning on empagliflozin a lot because it's a newer medications with good evidence in heart failure. Increasing the dose of enalapril will not be helpful in this condition because this is also a very optimum dose. You don't have to know that. You just have to know that empagliflozin is a heart failure medication with survival benefit. That's all the questions. Do you have any questions? I will share this document in the group as well.
Thank you, Majan.
And